for the introduction, and good evening to all of you. So I'm going to deal with oculoplastics X files today. All right. So we will keep it as a case-based series of case-based presentation. And well, as you all know, you are definitely going to get an oculoplasty case. And what is the common cases that you usually get? Ptosis and ptosis. Yeah. So this has been all throughout, right from my PG days. Can I have a pointer? Podium. All right. How many exam going PGs here? Majority? Well, that's good. We'll interact more. All right. I have no financial disclosures in interest, but I have affiliations. I have worked in few institutes before, and I'm still associated with other hospital other than my own setup in Bangalore. So, well, yeah, this is what we are trying to do here. Trying to make oculoplasty a little bit more easier for you. Do you think it's easy when you get an oculoplasty case in your exam? Confident? Wow, 120% confident? Yes, all right. So let us talk about this case first. A 6-year-old boy complains with drooping of eyelid in the left eye. So as you can see here, yeah, left eye drooping in a 6-year-old. So what is this? Yeah, up gaze, yeah? Superior rectus is involved. So there is a monocular elevation deficiency along with it. Anything else that you would like to look in a child who presents with a drooping of eyelid for your exam? Sorry? Lid lag and down gaze. What would that tell you? Yeah, whether it's a congenital, right? Yeah, you all know that it's due to the maldevelopment of the levator palpebrae superioris. So neither it contracts nor it relaxes. So there will be a down gaze lid lag. Okay. One of the other most important thing that you have to do either in a child or any patient who presents with ptosis would be a Marcus Gunn jaw winking phenomenon. Okay, so here you can see. So the child has a Marcus Gunn jaw winking phenomenon. Why is it important? Surgically, yes, it helps us to make a right, surgical management which is appropriate for this child. Apart from that, so what is the most important thing that you would look for in a child with ptosis? Amblyopia. Vision is very, very important, right? So in a child with Marcus Gunn jaw winking phenomena, the chances of amblyopia due to vision deprivation amblyopia is quite less, but still they can have anisometropic amblyopia due to the refractive, errors that which can coexist along with the ptosis. All right. A small baby presenting with the ptosis where the parents were totally worried. Well, as you can see here, this is also a case of Marcus Gunn jaw winking phenomenon. When the baby smiles and clenches the jaw muscles, you can see the ptosis is getting corrected. So you don't want to deal with these children at this point of time. You don't want to operate on them. So you're gonna observe these children, and as a part of a cosmetic correction of the eyelid, you might take them up for a surgery later, or even earlier if the parents and the child is bothered about it cosmetically. All right. So basically you all know blepharoptosis classification, you have to know it. These are the typical questions that would come for your theory as well as for your practicals. They would start with classification. And you know this classification, I assume, yeah, it's congenital and acquired. Simple and complex in congenital. So what are the complex congenital ptosis that you know? Already you saw one, the Marcus Gunn jaw winking phenomenon associated. Then blepharophimosis syndrome, perfect. Sorry, yes? Due to Well, so the monoocular elevation deficiency, that's what you're talking about. Third nerve palsy, right? Congenital third nerve palsy associated with ophthalmoplegia, they can have ptosis. Then associated with a pupillary abnormality, Horner's syndrome. Okay, anything else? Any aberrations, okay? Third nerve aberration can also cause a complex congenital ptosis. Acquired, you know, all of you know that the most common acquired ptosis is aponeurotic ptosis. They can be myogenic due to myasthenia gravis and chronic progressive external ophthalmoplegia, alright? Neurogenic, mechanical and traumatic. Why is traumatic included as a different classification here? Trauma can cause everything, right? It can cause injury to the muscle, causing a myopathic ptosis. It can cause injury to the nerve, causing a neurogenic, right? It can cause scarring, everything, edema, mechanical ptosis, right? So it actually comes under a separate heading in acquired ptosis, all right? Yeah. So this patient, who is like a 28-year-old male, came to me with again a coupling of drooping of eyelid. So from the pictures, what all things can you tell me, whether it's congenital or acquired, and why? Congenital. Who gave me that answer? Why? Yes, why? Lid crease is absent, absolutely. Okay, so he came, sat in front of me, and well, I was almost sure that it's a congenital ptosis. And then he says, no, it was not there when I was born, it recently came, it has been there progressing for the past 4 years. I was not born like this. So what do I want to do? Photographs. Okay, so photographs, asking the patient's photograph is very, very important in order to see how the ptosis has progressed. To my surprise, he was right and I was wrong. All right, so his aponeurosis has retracted so much above that the lid crease has been absent, right? Yeah, yes. So you can see this is how he was as a teenager. During his early 20s, it started, you know, kind of drooping, and now this is a situation. In fact, his LPS action was very, very low. All right, so this is how it is. So you have to always compare the previous picture, especially when an adult presents with a ptosis. It could be congenital or it could be an acquired which behaves like a congenital. All right, yeah. A family history is very, very important. As you can see here, mother with bilateral ptosis, undergone like series of surgeries. You can see the scars over here and the child presenting with ptosis. Not associated with family history. As you can see here, both these are twins. Okay, so the one doesn't have ptosis, the other baby has a ptosis. All right, so family history is again very, very important in ptosis. Aponeurotic ptosis usually presents in older patients. If it presents in younger individuals, what could be the cause? Traumatic. What? Yes. You're there, tell me. Blepharochalasis. So what is blepharochalasis? It is a repeated recurrent swelling, inflammatory swelling of the eyelid, which causes stretching of the levator palpebrae superioris, stretching of the skin, causing very thin skin. They will be having something like a chalasis, right? Something like a dermatochalasis that you see in older patients. They will have blepharochalasis in the younger patient. Okay, blepharochalasis. Then VKC, right? Which has been, yeah, AKC, VKC, constant rubbing, contact lens use sometimes can cause acquired aponeurotic ptosis in younger patient. All right. So history, the age of onset, the mode of onset, laterality, diurnal variation is again very, very important, especially when a patient who is suspected to have an aponeurotic ptosis in an elderly individual. You should always ask the history of diurnal. You don't want to miss, because by giving a tablet you can treat these patients. You don't have to overwhelmingly go take a step ahead and do surgery in these patients. Progression, again very important. History of trauma and prior surgery is very, very, very important. Most of the, some patients, not most, they can hide the previous history of surgery from you. You know, they just come to you as a new patient. And well, when you open up, you see all fibrotic tissue over there. So it helps you to plan your surgical management better. Very important. All these things should be in your history when you take a case for ptosis. Medications, if any, and periocular and systemic symptoms are again important. In case of Myopathic ptosis, right? Myasthenia, all right. So again, whenever you examine a patient, don't directly go and start the ptosis measurement. Okay, facial asymmetry, the facial features, head posture is very, very important. It gives you a lot of clues, okay, to what the actual etiology and etiopathology of the ptosis would be. All right, yeah. Now, when we talk about ptosis, to be very specific and accurate, you should be mentioning it as blepharoptosis. Okay, there are different other ptosis. They can be brow ptosis. They can be lash ptosis. Okay, so whenever you write it in your examiner will be more impressed if you write down your diagnosis as blepharoptosis. These old patients who come to you with acquired aponeurotic ptosis, they can in fact have brow ptosis also, dermatochalasis, brow ptosis. So even if you correct the ptosis for them and not correct the dermatochalasis, what's going to happen? The skin and the brow is going to hang over here. So as a surgeon, it's also important for us to know that these associated things are also ruled out. So it's blepharoptosis, all right? Yeah, periocular fullness, deep superior sulcus deformity, frontalis overaction again is important. Scars, look for eyelid laxity also. Okay, now ptosis measurement, I'm sure all of you, majority is exam going PGs. So these are the list of things that we want to look for. Okay, I tell all my residents, I make them write 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, palpebral fissure height, you want to measure it straight. So how do you measure the palpebral fissure height? I'm asking only you guys. Let me turn this side now. Yeah, how do you measure the palpebral fissure height? Yeah, center of the upper eyelid to the corneal reflex to the center of the lower eyelid. You should mention that. You can't go to the side laterally and medially measuring it, right? You have to look straight gaze as well as down gaze, because down gaze will give you a clue. As we already mentioned, in congenital, down gaze, it will be more. Whereas in acquired aponeurotic ptosis, it will be less. All right, yeah. Margin reflex distance. Don't talk about MRD 1 is important, not 2. Don't talk about 2 and 3 at all. Okay, only what matters is MRD 1. But if at all the patient has some scleral show, that's when you will be talking about MRD 2. Forget about MRD 3. Don't complicate your viva or practicals. LP's action, again very important. Lid crease distance, very important. All right, and even finding a lid crease, if it's absent, that indicates that it could be a congenital ptosis. Tarsal height is important. How do you measure the tarsal height? Avert the eyelid and then measure the tarsal height, because it's important. Well, although most of us have shifted to mullerectomy, there is a surgery called Fasanella Servat surgery, where we also excise a part of the tarsus. So if the tarsal height is not adequate, we would definitely say no to Fasanella Servat surgery. It's contraindicated. Bell's phenomenon, very, very important. All right. If the Bell's phenomenon is poor, you're going to tell the parent that we will correct, but we are going to undercorrect, because there's going to be corneal exposure. You have to actually warn them regarding all the post-operative anticipated complication. Lid lag is again important, because after ptosis surgery, you're going to have a lag. So there will be an exaggerated lag in the patient. Marcus gun jaw winking phenomenon, never forget it. All right? Yeah. Other tests are like ice pack test, fatigability test, and phenylephrine test in indicated cases. How do you do an ice pack test? You do it regularly? Do you check? Yes. How? Yes. And how many minutes? You want to put it for 10 minutes? 5 minutes? 2 minutes. Okay, never more than 2 minutes. You have to try putting the ice pack on your eyelid. Okay, it is so painful. Alright, so never put it more than 2 minutes for a patient. I'm just going to show a quick video for you. Alright, so this is a patient. Yeah, ptosis of the left eye. Ice pack. So this is how we place. We take a gloves, put the eyes inside the gloves. You get those larger packs, but that's so big, and heavy. Take a gloves, put 2 cubes of ice, small cubes inside it, and then check for the ice cube test. So certain centers that you go, they may not have the facility, but then ask for it. At least you have asked for it and write it down that ice was not available and I couldn't do it. Phenylephrine test, again in milder ptosis. Okay, so like 2 millimeter ptosis, you want to know Muller's muzzle. Yeah, okay, so if it is good, as you can see here, it's completely corrected over here. We can go ahead with mullarectomy in these cases. All right. So other rules apart from these that we have discussed, you have to always rule out pseudotosis. I'm sure Dr. Ramesh Kekuneya is going to cover about strabismus and things. Assessment of best corrected visual acuity is very, very important. Okay. So amblyopia is not always a visual deprivation amblyopia. It could be due to an refractive error, okay, and isometropic amblyopia also. Assessment of ocular motility, never forget it. Never forget it. Okay, if you miss that finding in your exam, you are almost sure that you will fail. All right, yeah. So this is a 16-year-old female presenting with a drooping of eyelid in the left eye. Mild, moderate, severe. All well. Moderate. Congenital acquired? Acquired. Why? Lid crease is high. Okay. All right. Confident? 100% confident. He always nods his head. Huh? Measurement you want. Photographs. Well, I'm going to show you something else. All right. Yeah, okay, so cafe au lait spots, all right, yeah, you can see these neurofibromatous lesion over here, okay. She just came with ptosis, okay, but you know what suspicion I had? You can see all these, yeah, pigmentation over here, and well, you can see this tiny lesion also sitting over the eyelid. Okay, so you have to really look into these minute details. So systemic evaluation is also important in ptosis patient. Okay, so just have a quick evaluation, or at least ask them, you know, if you feel that there is something abnormal, something thicker in the eyelid. It absolutely looks like an acquired ptosis, isn't it? Yeah, all right, so that's quite important. Going to the next case, an exam case. Okay, proptosis. We're finished with ptosis. If you have any doubt, you can ask me later. Oh, sorry, I didn't change this. I'm really sorry for it. Okay, so this is a 46-year-old man with proptosis of the left eye. Okay, so what view is this? Worm's view. What is Ant's view? Bird's view? Bird. Bird is flying above, they're looking. Worms and ants is from below. Okay, so this is a worm's view. You all are confident in doing exophthalmometer? Yeah, what are the exophthalmometer that you use usually? And what is the standard? Hertels? Lewds is not standard. Okay, why is Hertels considered to be standard? Yeah? Where do you keep it? Yeah, so it's a constant. Okay, so that is why Lewds you can, so but most of some centers may have only Lewds. It doesn't matter. But the standard is Hertels and Nagels also. All right, yeah. So these are the exophthalmometers that you should know. So what do you want to do next is go for a CT scan, right? Yeah, so thyroid, whenever we will go with the examination, I'll touch a little bit on the theory but not too much. So what do you think here it is? What is it? You have to read the CT. Axial cut. Axial what cut is it? The lens is seen here. Mid-axial cut. Very good. Yeah, and what do you see here? This is the right eye. Left eye, the medial rectus and the lateral rectus is enlarged. So what is typically seen here? The tendon is spared, right? Yeah, classical of thyroid eye disease. And what cut is this? Coronal. So you can see the muscles, how it is enlarged. Okay, medial, lateral as well as inferior rectus. So how do you differentiate it from a myositis? Tendons, yeah. Okay, so as you can see here, it is kind of not really well defined, kind of a moth-eaten appearance over here because of the inflammation in the muscles per se, and then the tendons will also be swollen. Okay, so this is how you differentiate. So apart from that, the most important thing, so proptosis, two differential diagnosis, mostly it is NSOID or TED. Okay, you might land up with a TED case. So mostly you have to look for the lid signs. If lid signs are present with proptosis, it is invariably a thyroid eye disease case. So you will be, some examiners will be asking you all the lid signs. How many are there? 25, like minimum 25. So you don't have to know all the 25. At least learn 10. Tuck, 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 tell, start telling it, and then they'll tell you to stop at 6. Alright, but you should be knowing all the lid signs, and it's a favorite question in any proptosis cases for any examiner. So what is this sign? Stellwog sign. Okay. The scary-wary look is? What is Van Graaff sign? Down gaze lid lag. Okay, so the certain lid signs will not be evident in very early thyroid eye disease, but that down gaze lid lag, Van Graaff will be present in most of the patients with thyroid. Okay, so these few important ones you should be definitely knowing. All right, now anterior segment evaluation is also very important in thyroid. You all know there will be exposure, right? There will be conjunctival congestion. They can even have a lot of SPKs in the cornea. Okay, you have to look for an epithelial defect. All these things are very, very important. So congestion over the insertion of the muscles are also a clue to thyroid eye disease. All right, yeah. Have you heard about this? Yes? How many? 1, 2, 3. Okay, very few. 4. Very few have heard about this. Okay, so this is how we actually evaluate the patient, and it will be very nice if you get a case and if you write it down there and just draw it. It will be very impressive for the examiner. So this is the natural course of thyroid eye disease. Okay, so they have this dynamic phase. Okay, then they peak, and then they go for a static phase. So by 24 months, any thyroid eye disease, whatever complications they create, will settle down. All right, so you need to know from the history, you need to know what is the phase of the patient. Okay, and accordingly you will be taking certain very crucial decisions for the management in these patients. All right, you have to go back and read all these things. I may not be able to cover everything. Classification of thyroid eye disease, again very important. You know the list of classification. Again, these names every examiner is very fond of. Okay, so what we currently use is basically the clinical activity score. You know all these classification? Yeah? You should know it. Okay, at least know briefly about all these things. So what we currently use is the clinical activity score or the Moritz score. How many of you have heard about the Moritz score? Good. Okay, so it will be nice depending upon the findings that you get in that patient, you write down and then count it. 1, 2, 3, 4. There are 10 scores. Okay, anything more than 3 is considered to be active. All right, yeah, so it's very, very important. You have to go back and read about it. Okay, you got the name now. All right, yeah. Okay, so now leave about thyroid. Thyroid is usually an axial proptosis. So you can have an abaxial or eccentric proptosis also. Quite rarely you might get a case. So at that point, measurement of dystopia is very, very important. Okay, although you do hotels, so you might have, you should be carrying 2 scales with you. All right. So this is the normal eye center, a corneal reflex. Okay, and then how much it's deviated either inferiorly or superiorly. So this has to come in your exam paper. Okay, if it is an eccentric proptosis. All right, yeah. So this is from the ACSE series that I have, BCSE series that I have been always reading as a postgraduate student. So these are the 6 P's in any orbit evaluation that you should be talking about. Whether there is associated pain, the progression, proptosis, how severe, mild, moderate or severe it is, palpation, pulsation and periorbital changes. All right. Systemic examination again in a proptosis patient is also important. Okay, so this patient has a scar over here which indicates that she has undergone a thyroidectomy earlier. You have to go and see. Okay, if you think it's a hypothyroid patient, write down all the hypothyroid features. If you think there is hypothyroidism, look for the features of systemic features of hypothyroidism. Write it down. Okay, you don't have to list everything. Just say that there are few features of hypothyroidism in the patient, few features of hypothyroidism in the patient. It will be very impressive. Okay, yet another case of a small boy, baby, a 7-year-old child presenting with proptosis, acute onset in the left eye. 7 days old. What are the possibilities? Quick. These are all like, trivia questions. Acute onset, proptosis, what do you want to think? infection first and inflammation, right? Not a tumor definitely, right? Acute is infection mostly. In a child, yeah, it's actually from the posterior ethmoid sinus. What do you see here in the CT? Multiloculated, cystic, well-defined lesion. Okay, elevating the periosteum. So it's a subperiosteal abscess, alright, in a baby. We just went through the canthus, okay, through the caruncle, and you can see the amount of pus which has come. Smiling after 3 days of, incision and drainage, and this is after 6 weeks. Okay, he's doing fine. So you should know the onset of the disease in order to know whether it's inflammatory, infectious, or any tumors associated, but Dr. Honava will be showing you. 70-year-old male with watering in the right eye. These are like short cases now. So long cases, ptosis and proptosis. You all know that, right? Yeah. Lower lid ectropion. Do you want to add something in front of it? Senile. All right. Senile ectropion of the lower lid in the right eye. All right. Yeah. You all know the etiology of ectropion. Very, very important. I'm not going into the detail. All right. So this is a 36-year-old male with again ectropion. Senile? Definitely not. Cicatricial ectropion. Okay, so these are the common ectropions that you can get in your exam. It can be senile, which is very, very common, or a trauma patient with a cicatricial ectropion. The management is totally different, right? Yeah. So how do you evaluate a case of senile ectropion? Okay, is the snapback test. You all know the snapback test, right? You pull it, you leave it, there will be a snap. Okay, all right. The pinch test. Anything more than 5 millimeter is considered to be abnormal. Some patients can have very lax skin or a lax lid. All right, yeah. Then the lateral distraction test in order to know the horizontal lid laxity. All right, these are important. Fine. Anterior segment, again quite important in ectropion and entropion, because they can have exposure in ectropion, again rubbing of the cilia in entropion. Okay, all these things are quite important. So this is how the eyelid works. So for your theory also, okay, it's very, very important. 1 more minute. All right, this is a case of right eye lower lid senile entropion. Okay, after modified Jones procedure. Ill-fitting prosthesis, contracted socket. You can get a case of contracted socket. Okay, after DFG and Fornix formation sutures, after fitting a new prosthesis, it's important to know the grading of the and classification of contracted socket. Okay, because management depends upon the grade. Very important. So in those which is like repeatedly surgically done, retinoblastoma patient, radiated, okay, exenteration is the option in these patients. Last case, 26-year-old female with incomplete closure OD. These are all short cases that you can get. Lag of thalamus due to? I'm done. What are the causes of lag of thalamus? Most common cause? Facial nerve palsy. She had a congenital 7th nerve palsy. Okay, yeah. Thank you so much. Thanks for your patient listening. If you have any doubts, we can discuss later. All right?
Thank you very much, Dr. Fairooz, for those lovely cases and very nice interactive talk.